how all of these things tie in together. There are many aspects to maintaining certain narratives in the medical industry, and one of them seems to be using tests when it fits the dogma. For those of you that have read Virus Mania, you will be aware of the scandals surrounding the HIV/AIDS dogma, and in recent times we have seen something similar with the new PCR dogma. Why do institutions and establishment figures go after people for questioning the inconsistencies in the science, going as far as blocking their work or employment? Today I'd like to highlight some more peculiarities, such as the abandoned COVID shot that made subjects test positive for HIV, more PCR problems, and why pathways to true health, including potential cancer detecting tests, are being ignored. In February 2020, there was an interesting interview on Australian ABC Radio with Professor Sharon Lewin, who is the director of the Peter Doherty Institute for Infection and Immunity, and was discussing the emerging corona crisis. The interviewer, Dr. Norman Swan, starts with the following.
The pace of the science in this outbreak has been extraordinary. The Chinese shared the genetic sequence reasonably early, allowing the genetic detection test, called PCR, to be developed around the world, making definitive diagnosis much easier.
Well, I don't know about that, but at least he goes on to ask Professor Lewin to clarify this.
First of all, my assumption there that the diagnosis is definitive using this genetic amplification test. Is it definitive?
They're pretty good, actually, when we look at for the genetic code or use something called PCR to diagnose an infection. You can design the tools you use to detect the whole family of viruses or the specific Wuhan coronavirus that we're talking about. So they are pretty good, but every test is not perfect. Some tests diagnose a positive when you don't have the infection or miss an infection. So with new tests, we take a while to understand how robust it really is. But generally, PCR-based tests are highly specific and pretty accurate.
That's interesting. She says it takes a while to understand how robust a test is, but with corona they were rolled out straight away. And what does robust mean? I don't think any test should be introduced without knowing their positive and negative predictive values. What is the test actually for? Professor Lewin mentions specificity, but is probably conflating the analytical specificity of the test for genetic sequences with the diagnostic specificity of the test for the condition called COVID-19. I talk about this in my video, Behind the PCR Curtain. Unfortunately, the interviewer doesn't press her on any of these vital points of the corona narrative. In any case, today we want to focus on what happens next.
I mean, it's revolutionised HIV diagnosis because you're able to detect tiny, tiny amounts of the virus in your body.
Well, actually, we don't use the PCR-based test for diagnosis. No, we largely use antibody tests showing that your body's made a reaction, and that has an extremely high... When we look at testing, we look at two things, sensitivity and specificity. Sensitivity determines how many positives you identify when someone has it, and specificity says how often you might make a mistake or diagnose someone with it when you don't have the actual infection. So we use an antibody test for diagnosis.
So Dr. Swan seemed to assume that because the PCR was being used around the world for the apparent diagnosis of coronavirus infections, it must be used to diagnose HIV infection. After all, we've been told that HIV infections have been circulating for decades. And Professor Lewin has just assured us that the PCR-based tests are highly specific and pretty accurate. Obviously, he got a bit of a surprise when he was mildly chided by the professor who said that no, the PCR is not suitable for the routine diagnosis for HIV. He's inadvertently stumbled on the doublethink world of PCR and infection. We use it and we don't use it. It all depends on what we want to see. In fact, this problem with PCR has been long known about. A meta-analysis of available studies by 1996 stated in its conclusion, the PCR assay is not sufficiently accurate to be used for the diagnosis of HIV infection without confirmation. So perhaps we can forgive Dr. Swan for being confused that the PCR was reported as being accurate for the so-called novel coronavirus, but not for one that has been researched for decades. It was a shame he didn't press the professor on why this PCR application for apparent viruses seemed to be rather inconsistent. In fact, he could have probed further to try and elucidate any historical examples of alleged epidemics where PCR was found to be reliable. Now for the second part of the story, we go to March 2020, when the University of Queensland, Australia, was awarded millions of dollars to help cut the timeline for an effective vaccine for COVID-19 by 6 months. By August 2020, they were confident that large-scale production of their experimental product was just around the corner. They reported that in hamster models, the vaccine provided protection against virus replication and reduced lung inflammation following exposure to the virus. Virus. But then a few months later, they hit a snag with their phase 1 clinical trials when the human volunteers were found to produce HIV antibodies after receiving the shot. Well, earlier you'll remember that Professor Lewin advised that because PCR was unreliable for HIV detection, we needed to use a more sensitive and specific test such as HIV antibodies. But these guys worked out how to produce the antibodies without any HIV, and it was reported that it was unclear how long participants would continue to return false positive results. Apparently, Dr. Andrew Nash, the brains behind the Australian-made COVID-19 vaccine, knew they were taking a gamble when they decided to use harmless HIV fragments in their project. In fact, it generated HIV antibodies in all 168 trial participants who didn't receive the placebo. However, in the same article, Professor Paul Young stated, "We didn't anticipate that we would have the problem that we subsequently encountered." For many of us that have investigated HIV, this is where the mainstream theories get rather inconsistent. Listen to the reason that infectious diseases physician Paul Griffin gave for abandoning the COVID shot in April 2021.
So what the issue was is that one of the proteins included in that vaccine caused false positive tests for HIV. And while for a large proportion of the population that's of little concern, there's also a significant part of the population that need regular testing for various reasons. And if we can't exclude HIV in those people, then that actually has big problems.
So for most people, having these vaccine-generated HIV antibodies is not a problem. But for certain people who apparently need regular testing, it is a problem. It raises another question about whether these 168 volunteers who produced HIV antibodies now meet the Australian Department of Health's case definition for HIV, especially as it has been reported that the antibodies were persistently positive. I guess we may never know, as there's not many specifics that have been released to the public, and they probably don't want to add to the large database of HIV inconsistencies. We know that if anyone has a positive HIV antibody test, they cannot donate blood. So if any of the volunteers are watching, please get in touch with me and let me know if you are still allowed to donate blood. We can see that arbitrary definitions regarding HIV have been going on for years. In 1990, the CDC commissioned a report titled Methods of Surveillance for HIV Infection at US Sentinel Hospitals. Here they state that all patients are eligible except those with lymphadenopathy, fever, endocarditis, pneumonia, diarrhea, weight loss, thrush, drug overdose, drug addiction, alcoholism, hepatitis, gastritis, gunshot wounds, psychiatric conditions, headache, any cancer or mass, bleeding disorders, any skin disease, any sexually transmitted disease, organ transplant, and renal dialysis. Now we need to add abandoned COVID shot recipients to the list. I mean, what is going on here? This kind of selection bias clearly makes the HIV antibodies appear much more specific than they actually are. Maybe I'm going out on a limb here, but I wonder if the abandoned COVID shot has added another problem for the HIV establishment. My suspicion is that the generation of the HIV antibodies was an embarrassing surprise to them, as up to that point they were very excited about their vaccine. And now that they have worked out how to generate these antibodies, shouldn't this be an important development for the HIV vaccine that has been promised for decades? According to the mainstream theory, when someone gets HIV, the antibodies are generated too late as the virus has already invaded the cells. But the University of Queensland team showed that they could generate the antibodies in healthy volunteers. Professor Lewin informs us that the antibodies tell us that the body has made a reaction to HIV. We'll wait to see how this one is classified in the official archives. To continue the theme of HIV popping up in potentially troublesome places for the HIV/AIDS establishment, we now move to the area of cancer. In 2018, an article was published in the British Medical Journal titled "Less than half of women are diagnosed with ovarian cancer within a month of seeing a doctor, Fine survey." Now, the article raises a major problem with regards to the often late diagnosis of ovarian cancer. But what is equally intriguing is one of the responses to the article. Miguel Romero, a biostatistician from Spain, picked up on a quote from the Ovarian Cancer Research Centre director. "The dream is a screening program that works, but I think we are many years from that." In his response to this, Romero points out that nearly 2 decades ago, the presence of HIV-1 DNA sequences was documented in breast and ovarian cancer tissues. Dr. Romero is referring to the work from the late 90s by Eva Rakovich-Shulchinska from the Worcester Institute of Anatomy and Biology in Philadelphia. Dr. Arias published a paper reporting how she had discovered HIV-1 DNA sequences in breast cancer tissue. Yes, you heard that right, and we're not just talking about a loose association. 40 out of 40 of the breast cancers were strongly PCR positive for so-called HIV sequences, and as samples were checked moving further from the tumour, the PCR amplification became weaker. Okay, but could this just be an irrelevant finding, or perhaps the samples were just contaminated? No. The researchers checked for the same sequences in control breast tissue, as well as other areas of the body, which all turned up negative. But it wasn't just breast cancer where Dr. Arias was finding HIV sequences, because she had also found this pattern in prostate and gynecological cancers. Now, probably like most researchers, she was under the influence of establishment HIV and general virus theory, because Dr. Arias postulated that the results obtained strongly suggest that the long postulated breast cancer virus may in fact be related to HIV-1. She also appeared to be influenced by electron micrographs of what they termed viral particles in their samples. But reviewing their methodology, we can see they were obtained by ultracentrifugation of cell culture media. You can watch any of my videos on viral isolation to see why this is not evidence of viruses. As Dr. Romero points out, regardless of a link between the cancers and a breast cancer virus or other factors, this data represents a highly specific, albeit empirical, relationship between HIV-1 DNA sequences and breast and ovarian cancers. He also points out the problem of PCR specificity to diagnose so-called HIV infection, as even the manufacturers of the tests readily admit this. Dr. Romero's conclusion: this data raises the possibility of utilising a liquid biopsy, which is a blood test, to discover clinically unapparent ovarian malignancies. Given the prevalence of this hazardous neoplasm and the widespread availability of the appropriate PCR technology, this hypothesis could readily be tested. And he wasn't actually the first to suggest this possibility, as we can see from the Perth Group's magnum opus, HIV, a virus like no other. There you will find the following comment on Dr. Arias' work. Despite what HIV-1 sequences may signify in regard to the HIV theory of AIDS, given the prevalences and prognoses of breast and gynecological cancers, the findings are potentially a useful tool for the early diagnosis of such neoplasms, especially as a liquid biopsy. For all the women watching, this is potentially the dream of a screening program coming true, a simple blood test to detect ovarian or breast cancer before it is too late. I contacted Miguel to see whether there had been any interest in his comments he made in the BMJ, but he said there had been nothing to date. This is somewhat surprising given the problems we have diagnosing breast and gynecological cancers early enough. I searched a bit more and found that Dr. Arias had actually filed a patent application for using these genetic sequences for the detection and treatment of breast, gynecological and prostate cancer in June 2000. You are probably wondering why I didn't contact Dr. Arias myself. I would have, but from what I can gather, she died of a sudden stroke in 2008. So what does all this mean? I'll leave you with the following thoughts. The inventor of the PCR, Carrie Mullis, stated it was entirely unsuitable for diagnosing any infections, and yet in this regard we see it being used, or not being used, depending on the narrative. Meanwhile, Dr. RS found HIV sequences in cancer tissues in people who did not have so-called HIV infection or AIDS. But why do people without HIV have these HIV sequences? And to top it all off, despite telling us the HIV genome is unique, the HIV experts themselves and the manufacturers of the PCR-based tests say they cannot be trusted to diagnose HIV infection. Like the PCR, antibodies are also being used or not being used, depending on the narrative. These establishment theories appear to be built on a house of cards, and yet are desperately being held together. With regards to various human disease states, why do so many doctors and scientists tend to blame microorganisms, and in particular viruses? You don't need them in the equation to produce cellular dysfunction, changing genetic sequences, and antibody reactions. It could be one of the biggest mistakes going on in the medical world right now. A dogma that distracts from real wisdom about causes of disease and better paths to health. Stay tuned for more videos as I continue to question the industry narratives and attempt to shed more light on some of the alternative explanations that have been suppressed by the powers that be.